Okay.
Yes, I'm here. Apologies. I'm helping. Dr. Johnson does not have a panelist link, and she called me. So.
Okay. John, can you send a link out to Taya Johnson? Thank you. Michael Patriarca.
Hey, here. Good morning.
Good morning. Dr. Pliska.
Here.
Dr. Potterwelt.
Here.
Dr. Robert. Scott Schlacklin. Dr. Suarez.
Scott's here.
Good morning. Dr. Suarez. Dr. Taminga. Dr. Town. Dr. Thompson. Did I hear Dr. Thompson? Maybe not. Dr. Vo.
Yo.
Yo Vo. Good morning. Dr. Wagner.
Here.
Dr. Wakefield. Here. Dr. Wesley.
Here.
Dr. Williams.
Here.
Excellent.
I'm
All
glad.
right.
It's like being in class again.
And I know Dr. Johnson will likely be here shortly. So welcome, everyone.
And what's our tally? We have 22 people here. Again, thank you for being here today. I know there's a couple of people that need to leave early, and so we're going to try to be efficient and move our meeting along. But please let me know if you're going to leave early so that we can make sure that we have the quorum here that we're required to have to follow the Open Meetings Act. With that, why don't we go ahead and get started? First order of business is to look at the minutes from the September meeting. Take a look at it. Let me know if there's any modifications, and if not, I'll take a motion to approve.
Move to approve, Potterwilts.
Second, Ibrahim.
All right, I have a motion and a second. Any other discussion? Hearing none, all in favor of approving the minutes from the last meeting signify by saying aye.
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 Opposed, nay. Did anyone abstain? Hearing none, the minutes are approved. So now we're going to go into a series of updates, and we'll start with the communications outreach and engagement with the University of Texas at Austin. There's a handout, but Laura, I'm going to hand it over to you and let you lead us through this discussion.
Sure. Good morning, everybody. Glad to see everybody. UT Austin actually won't be presenting today. They were unable to make it, so I'll do a short and brief summary of what they'll be talking about today. On the agenda, on the next slide, you'll see we'll go over media requests, and I'll touch base on a new concept and initiative that I'm working on called the Community of Practice. And then I'll go into the brief bullets for UT-CHC, and then briefly touch on other activities. So we still continue to get a good stream of media requests about our programs, including TCHAT, CPAN, and the consortium and overall mental health policy. As you can see on the slide, we had two major stories that were published since the last time we met. The top one being from KUTX, which is the local Austin NPR station. And that story actually ran on NPR's Morning Edition, as well as other local NPR stations around the state. And it had over 600,000 impressions, or it had 600,000 reach, which means 600,000 people saw it based on the website numbers that these media outlets report. The second story that published was from Texas Public Radio, and we had Dr. Williams, as well as Rena Pardawali from San Antonio, who helped us do that interview. We also got additional media requests from ABC News on mental health policy, which we referred out to a partner, KSAT, which is in San Antonio broadcast station, that wanted to do an interview about TCHAT, and then KERA, a local Dallas NPR station, about PeriPan. And we referred these out to our partners, and these have yet to be published. If they do get published in the next couple weeks or months, I will definitely let you guys know. This is just a pullout quote from that story, just to show you that this coverage that we are getting is still very positive. As we look at overarching communication strategy for the next year, it's just good to know that we can kind of take a step back and not be too proactive on the media, because we're actually getting a lot of interest around the state from different reporters in the aftermath of the Uvalde tragedy, and as discussions continue around the state about mental health policy. One of the other initiatives that I wanted to talk about is a community of practice for communications. We have touched on this during the CPAN coordinators meeting, as well as the CPAN leadership meeting. In essence, a community of practice enables colleagues to learn from one another through the sharing of successes, issues, ideas, lessons learned, and other relevant aspects. And it actually creates a better environment for innovative and consistent and effective public outreach for the consortium. As you know, we've got so many amazing teams working around the HRIs who are doing communications work. Within those teams, you've got several different roles and responsibilities, from the CPAN coordinator to media and outreach and communications to providers who are doing some of these communications functions. And we really want to set everybody up for success by having consistent voice, consistent branding, tailoring the different materials to each HRI, as well as sharing best practices for outreach so that you guys can continue to see the success of providers enrolling, as well as schools utilizing TChat. We're going to have our first community of practice meeting during the November CPAN coordinators meeting, and we'll have a presentation by the UT Austin Center for Health Communication to do a training on social media. And we'll touch base with all of our communications contacts about how this community practice can benefit them most. Some of the other activities that UT Center for Health Communication are implementing right now are listed here on this slide, including materials and collateral and technical assistance to each of the HRIs on our texting initiatives, direct consults as well. So the texting is going to roll out in November. We've sent out information to all of the different coordinators with specific HRI branded materials, as well as newsletter content and social media posts. Whenever Dr. Williams and her team are ready to implement the direct consult piece statewide, we will work with our CHC team to develop those materials as well, and do further outreach to stakeholders and partners. We've just completed a video to promote CPAN on our digital channels. And that video is it's got a 3-minute, just about a 3-minute longer video about all of the different aspects and benefits of CPAN to providers. And then it's going to be cut up into different sections. And those videos are going to be implemented and distributed through our digital strategy. And it'll be aligned with work that we're doing with the HRIs to promote that video. Once we have those final and uploaded to the website, we'll share those links with you guys. It's an animated video, so that's how it's a little bit different from the one that's on our website currently. And it goes into some of the formative research that CHC developed about what messaging works best with providers. In November, we're going to be focused on storytelling through gratitude for our social media posts. And so we've been working with HRIs to pull testimonials and quotes from the different providers about how they feel or how they've benefited from CPAN. So this should be a really, really nice presentation on social media, on our Facebook and LinkedIn pages that you guys can share and take a look at through November. Again, the CHC is going to be providing social media training to the CPAN coordinators and the community practice of communications professionals in November. In December and in the new year, we'll be focusing on reviewing the consortium's web pages around CPAN and all the resources that are there, because we've been developing so many different new pieces of collateral. We want to just make sure that all of our communications are consistent and well branded and accessible on our website. And then lastly, it was a request and it's part of our scope to look at how we can support the HRIs through consistent content for newsletters. CHC is also going to be working with Dr. Wakefield's team and the Kosh on outreach planning for the PeriPan initiative. We've already developed several collateral pieces for PeriPan, and the HRIs that are implementing that pilot have those, and we'll be meeting with HRIs as we go to find out how we can best support them in their PeriPan outreach. Lastly, our other activities that we're doing at the consortium is we're continuing our partnership with the Texas Pediatric Society. We will have digital ads that run every 3 months that will correspond with the different content and subject matters that we have with the UT Austin CHC. So we'll focus on, for instance, texting in November and in the new year, direct consultation. We are also going to do monthly newsletters for the Texas Pediatric Society. Right now, they have just under 5,000 pediatricians signed up for that newsletter, and the CPAN newsletter that's a part of our partnership that goes out to all of those pediatricians has about a 57% open rate, which is outstanding. On the social media front, the consortium is going to be working with UT Systems external relations team to come up with a plan for social media for the consortium so that we can maintain relevancy and presence in the public policy and public interest realm for mental health policy. Lastly, we're going to be in the next year or two looking at refreshing our webpage, which is something I think we all talked about. Our initiatives are getting larger and more complex. Our audiences are diversifying. We need to be able to talk to not only policymakers, legislators, schools, and providers, but we also need to be talking to parents who have questions about the programs that we're utilizing to help their children. And so this webpage refresh is more of a long-term goal. And we'll be working with your teams on that as well to identify and hone in on those specific messages for different audiences. And that's it from communications. If you guys have any questions, I'd be happy to answer.
All right, very good. Thanks, Laura. Any questions for Laura about the communication strategy and the approach? All right. Hearing none, again, thanks, Laura, and look forward to the continued updates. A lot of activity. So before we move forward, there are several people that have joined us since we did the roll call. So if you've joined us since we did the official roll call and you're on the executive committee, if you'd identify yourself, that'd be great.
Jair Soares here.
Thanks,
Carol
Jair.
Tamminga here.
Carol.
Taya Johnson.
Good morning, Taya. Dr. Johnson, good to have you here. All right, anybody else? Hearing none, let's move to the next item. Dr. Lopez, you're gonna give us an update on the program evaluation that your team is doing?
Yes, good morning, everyone. We have a brief update for you today. We have been focused on the fiscal year 22 data and making sure that all of that data collection is as clean as we can possibly make it. So we really appreciate all of the effort that the teams have made to respond if we are missing any data or need to have a conversation about any corrections. So we really do appreciate that. And as a part of that, we are, of course, then focusing on the year-end evaluation, capturing all of the data metrics for the year end. And the exciting thing about this time around compared to last year is we have that opportunity to go a little bit deeper into the data than we did the previous year, because we have a full year's worth of data across the majority of the programs. That data is much more consistent and good data to use for this year's evaluation. So we're excited about being able to really explore that a little more deeply this time around. We're also helping to support UT System as they develop the legislative report. And so that's been our focus over the past month. And we're excited to be able to bring you some of that information in the coming months at the next meeting.
All right. Very good. Any questions for Dr. Lopez? I don't see any, but thanks, Molly, for all the help in putting that legislative report together. Again, for the new members, every biennium before the legislative session, we put together a comprehensive report of the activities and to provide it to the legislature so they can see the great work that you're doing. And so having the data to tell the story is really important. So thanks for your help in pulling that together. Along those lines, another document that we've been putting together, and your team has been helpful, along with Lachelle and her team, is we've been reporting monthly data to the governor's office and now to key legislative offices on the rollout of TChat in the schools. And that's going to be very important for us in order to continue to follow how we're proceeding and meeting that mandate from the legislature to get TChat into all the schools in the state of Texas. And so thanks for the question, or answering our questions and providing us that data. And it really is being viewed at the highest levels here in Austin to make sure that we're moving forward on these initiatives. Right. Any other questions or comments? Hearing none. Again, thanks, Molly. I appreciate you being here today. Let's move on then to the external evaluation update. Dr. Savas, Dr. Peskin, I saw that you joined us a little bit ago. Let me turn it over to you.
Okay, and I am going to echo that we've been spending this last month really compiling, analyzing, cleaning data for our final report for the previous year. So I'm just going to review the activities without showing you the data results, which we hope to be presenting more of in our next month. But our team's major activities have been focused on analyzing and interpreting the data from the TREAT and CPAN and TChat databases for the annual report. And much like the Molly just said, we've been working on reconciling data questions with the internal team so that we are consistent in helping report back issues with TREAT if needed. We're also finalizing the CPAN survey data that we conducted among 75 physicians. Our response rate was not quite what it was last year. We also have TChat school surveys with 161 people at the school level. And these surveys both focus on facilitators and barriers to implementation, including organizational factors that influence implementation, and we'll be compiling and reporting that data and results in our report. In addition, we've completed and finalized the analysis for the CP Week in-depth interviews. We've completed with 11 of the CP Week participants. That includes 6 residents and 5 fellows from the different 10 different HRIs, and 2 did not at the time have trainees in place. So the cost data surveys also have been completed. We had great responses from psychiatrists and program managers at all the CPAN and TChat HRIs. That was about 78 responses. And the health economist lead, Dr. Larson, is finalizing the cost analysis, and we're working with him to ensure that the data we have are matching the activities they represent. And we'll be reviewing that also with the cost team before we finalize the results. So we're reviewing the methods and data collected to provide the cost also of consultation calls, which was one thing that we wanted to focus on for this last year that's different from the first year. And then we've also continued to work on building the TChat and CPAN dashboards that our plan is to provide monthly updates, and this is to guide both process evaluation for us and to help implementers at HRIs track their what clinics they're onboarding, who's engaged in the program, who's not, so that they can also use the data to identify non-users. Those would be, for example, enrolled clinics that have made no calls. And we're going to be working to provides instructions, like a little user's manual, so that they could select out those clinics and download their data so that they can make calls to them to help follow up and understand non-use. And we will also provide instructions for that. So I could, if you are interested, share this dashboard. Before I bring it up, I just wanted to say that this is only the TChat dashboard. We shared the CPN one and shared the link for the CPN one to Dr. Williams so she could look at it, provide us feedback, and see if this is going in the right direction for them. The TChat one also has in the background, you'll see the Childhood Opportunity Index. We're using this instead of the CDC Vulnerability Index score because it has more specific domains that matter for children. So it has about 29 indicators that cover environmental, health, social and economic factors, and education. So, and these are collected at the neighborhood level. So we were able to include that in our map. So if you want, I could share my screen and just show you what that looks like, just briefly. And again, this is something that you'll, it's a little sensitive to the touch. So I want to share my screen if that's okay. Let's see, I'm doing this for trying to figure out how to, not sure it's working. I'm not sure you can see my screen or not.
We're not seeing it yet.
No, okay, I'm gonna try it again. I may be frozen. Darn it. I'm hitting that green arrow, but it's not like letting me choose my screen share. So I'll let you know. I can share the well, we'll definitely be sharing the link with Dr. Williams. Let me see if and then it will go out to the HRIs. I'm just gonna try one more time.
Let me just check with my team real quick. John, can we make her give her the opportunity to share her screen?
Everyone in the meeting has the ability to share
Okay.
their screen.
Okay. So it should work.
John, right now it's disabled, so you'll have to enable it.
Let me make sure that that's it. We try now.
Okay. There we go. Okay. So are you seeing this map here?
We are. Yeah, it's working now. So thanks.
So you can zoom in like this to really get at the, a local level. And so I'm just like randomly picking up a spot here. So if we wanted to go into College Station, so these are the high opportunity, they have a high versus very low childhood opportunity. And then if you click on the dot, it gives you what HRI and the address and MRU is in place. We're going to be adding phone numbers on here so that if users want to use it to contact that school and get in touch with them, they could. And then it has percent of students on free lunch here, and urban rural index. So that shows more urban area. So the color right now is corresponding to the COI. Like I said, here you can see that you can use this right now to select out which schools you want to see, the campuses. So right here I had selected MOU in place, and counties. You can take out major highways. And then the COI is here. But if you wanted, for example, to look at onboarding schools, you could do that, or TChat MOU in progress, planned. So this one you can see has mostly in place, or declined. You could even just do declined. So this is at the state level. So this is hopefully going to be a user-friendly way for people to just keep in, the implementers to keep in touch with how are they looking And we'll use it also to we use the data itself to do analysis, but this month we'll be updating monthly. And we're working with Dr. Rampool. He's in the EPI department at the UT School of Public Health. So he'll be uploading data so that this is kept current. And I'm just scrolling down. But if right now we're really in the welcoming feedback as people leads start to see it and see how this is useful to them. It's also hopefully going to be useful to the communications team so they can track potential more use and engagement by those schools or clinics enrolled by what their communication strategies are targeting. So if they're targeting certain geographic areas, hopefully we can see there's a bump up in enrollment and track it that way. So I'll stop sharing, but I welcome any questions or comments. And yes, Laura will be sending you the link to this one right after I'm done here.
Yeah, that's very nice. We'll make sure we share that with everyone. But as we're, again, moving TChat to every school in the state of Texas, having that ability to see where they are and the vulnerability of kids in those areas will be really important. So Joe, Dr. Blader, I see you're, actually, Steve, you're on your screen, it says Joe Blader, and you left the screen, so I couldn't see you. So it's
right.
Actually Dr. Blader.
Yes. That's right. I had to use Joe's link because for some reason mine got lost. So you'll just have two of us today, if you can stand it. So my question was, I was hearing the part about non-use or people calling. Wouldn't mind briefly repeating that? I didn't quite catch that.
So for example, like in the clinics, and Laurel and Molly and everyone with the definitions can chime in here if I'm not representing it clearly. But the non-use is when you've enrolled a clinic and they have an MOU in place and they've been trained up and they know about the program, but there are no call. They're having been called.
I see. Got it.
Yeah. And it
So you're talking that's in reference specifically to CPAN.
Yeah, that and TChat would be the same thing. Like if they don't have referrals, we might, maybe they don't need to make referrals, but there could be a check-in to make sure
I see.
They're not missing information they need.
With TChat, it would be the school that's enrolled.
Exactly. Yeah.
You're not talking about individual patients, but rather either the clinic or the school.
Yes, exactly.
Got it. Thank you.
Very good. Dr. Vo, Alex?
Yeah, I just have a quick question about when do you expect to be able to have the full report for us to review?
Yeah, so we have we have these packets that we created, and we thought we're going to plug in the latest data to them because we had year one data, but so much activity has happened after that kind of setup year that we wanted to update it while we're doing these year two analyses. So I'm hoping in December you'll get emails saying, here we can now meet with you with more recent data at the HRI level. So yeah, we have the year one data, but I think that it's worthwhile waiting because there was a lot more going on this last year.
And then Alex, for our team, for the report to the legislature, that's due in December 1. And so we should be able to share something right before we submit it to everyone on the executive committee.
Does that include the cost benefit analysis as well in that report?
So the cost analysis we'll have for our year two report. And we have it, we want to review it to make sure we've correctly associated costs with activities right now, but that should be in our year two report. Yeah, that's due soon.
But wouldn't be in the LBB report at this time. Okay. Any other comments, questions? Hearing none, Dr. Slops, thank you again for your work, and look forward to looking at that map in detail and seeing the other information you're going to be providing us. That's awesome. Thanks. All right. Why don't we now go to item number 4, some additional updates, and start off with the fiscal agent update. Linda Haster, let me hand it off to you.
Okay, thank you. Let me share my screen for just a second. Get the document up. Apologize. One of the disadvantages to having the multiple screens, and you gotta chase everything. All right. All right, so the update we have so far is we wanted to confirm with you that we have negotiated the majority of our subaward agreements so that each of the HRIs could begin implementing their programs with the ARPA funding that was allotted to them effectively. And so 7 of them have signed. 4 of them are still in negotiation, but they're close to being wrapped up. So we anticipate that soon. We have started to receive invoicing from those that had executed agreements. Due to our lateness in getting the executed agreements to them in late August in our fiscal year end, most of those invoices will be starting to come next month as they start making the costing allocations and stuff at their institutions to get the invoicing to us. But we have received a few, we're routing those through, and then we will be consolidating those and sending them to TCMHCC for reimbursement ourselves. And then the final update on reporting, this will be the quarter report that we'll be able to start reporting and reflecting data from each of the HRIs and what they've spent. And so that'll be submitted at the end of the month. TCMHCC will be submitting that based on the information that we've provided to them. So that's what we have for an update. Are there any questions from the groups and concerns about the contracts or invoicing at this point?
All right.
All right.
I've seen any hands in this room, and I don't see anyone that's raised their hand virtually. So thank you again, Linda, for the great work that you guys are doing to keep us on track with the ARPA funds.
Thank you.
Thank you. So let's next go to a series of updates from our team for the administrator from UT System. Lachelle, let's start off with you.
Yep, thank you very much. Very brief updates, and then I'll hand it over to Jonathan for the contracts and any financial related activities. Just want to say everybody's been getting our their status reports in. Thank you very much for that. We have been reaching out to gather some additional information for that LBB report. So I appreciate everybody's review and quick response on those questions. We will be changing the process for submitting status reports in the near future. We've been doing site visits, as you all know, and one of the items that have kind of come up time and time again is around communications and just the number of requests that they're getting from different bodies, whether that be the internal evaluation team, external evaluation team, UT System, and then COSH. So we as a group are going to be meeting to look at what requests are coming down and being more thoughtful about how those go out to the HRIs. The internal evaluation team and I have had some conversations about putting Monet in charge of facilitating all of those status reports. So we will be sending out an email this week laying out what that process looks like. So instead of some things going to David Lynch, some things going to me or to Monet, Monet is going to be our primary point of contact for all status reports moving forward. So expect that to come through soon. And then on the site visits, we've completed majority of our site visits at this point. We've got one to UT Health Science Center, San Antonio this Friday, and then we're doing Baylor, I believe the week after that. And then that just leaves Tyler for us to finish up our full sort of statewide travel schedule. It's been a great experience just meeting all of the teams and seeing what they're doing on the ground. I think we've learned a lot. And so we're going to be taking the month of December to really pull together all the information that we've gathered as we've done these site visits come up with, the themes and then come up with a plan for how do we address the issues and how do we better promote the best practices that we've identified during these site visits. So look forward to putting that together and then presenting it back to the team. So Jonathan?
The only update, I guess, would be around the PIA amendments. You all should have received an amendment to the PIA. I've received a few of those back, which are being routed for signature here at UT System. And if you have any questions about the ones that you have received, for those of you who have not returned it, please feel free to reach out. Thanks.
Okay. Sarah, was there anything from you?
Everyone has been great at turning in their ARPA status report. So I wanted to just say thank you. I know it's a little bit of a different reporting structure, so very much appreciated and thank you for the hard work.
Yeah. Very good. And again, I want to echo Lachelle's comments of appreciation to the HRIs for the site visits. Those have been very helpful. The team comes back and is always enthused to tell me about the great strategies and new ideas that are being generated at the local level. And those are helpful for us to then share with other HRIs. And so again, thank you for all the effort you're putting in to make those successful. I guess the other part of the administrative update, we're continuing to get ready for the next legislative session. At the last meeting, we talked about the budget ideas that we have. We're having conversations with select legislators and their staff related to what those needs of the consortium are. Beyond that, I don't have an update, but again, want to make sure you guys know that we're working those issues right now to try to make sure that we get the resources to meet the new goals that the legislature over the summer have given us to make sure TCHAT is available in all the schools and to build out these additional programs and to be ready for the change when ARPA goes away, and how do we make sure we continue programs the way that we need to continue. So with that, let me stop there and see if there's any questions for the UT System team from the members of the executive committee.
No, just a lot of work. I want to say thank you to that whole team because you guys are great. You know, you keep us kind of moving in the right way. You make sure that we're being responsive. We couldn't do this, I don't think, as a consortium without what you guys do there. So thank you, David, for your team.
Thank you, Alan.
I second Dr. Puddles.
Well, thank you very much. It's a privilege for us to be able to work with you. And again, our team is very excited about the progress that's occurring. And again, it's exciting to see the different strategies the universities are using in the local community and figure out how do we share those strategies with each other to sharpen the programs. So again, thank you. Yep, go ahead.
I wanted to say one thing as well. This is Luann. We are also, the work that you're doing on the ground with implementing TCHAT and CPAN, I want you to know that it's being recognized not just in Texas, but in other states as well. We've had a lot of interest from other states, especially in TCHAT. How are we doing TCHAT? How has it been implemented? How does it link with our CPAN project? And so we are providing a lot of information and just presentations. I know Dr. Williams is going to be going to provide some presentations out of state. So I just want you to know your work is really being recognized out there, and people are very, very interested in how to make connections between schools and the mental health system. So thanks again for all that you do. And it's been a pleasure meeting a lot of you in person as opposed to online. So keep up the good work.
Yeah. Yeah, the other positive feedback that's coming to us is as you're working in the schools and being very responsive, and especially in the rural areas, a lot of the superintendents of the ISDs are telling folks here in Austin that what you're doing really has been essential. And so that's very helpful to us as we continue to build the program. So thank you. Why don't we go to the next item? Dr. Wakefield, let me give an update on PeriPan.
I'm happy to do it here. We also have some bullet points in the Kosh presentation. Would you like me to do it here or later?
If you want to say a few words, you can do that. And then if there's something additional there, that's fine. Whatever you feel most comfortable with.
Sure. Well, I just have a brief update. We are live. All 4 HRIs that are in the pilot site are staffing from 8 to 5, Monday through Friday, with a reproductive psychiatrist and taking calls. But the main focus over the last couple of months, just like it was for CPAN at the beginning, is enrollment and engagement in these pilot regions. So I just can't say enough about the work that these teams are doing. We are meeting regularly to talk about engagement strategies and presentations and how we can do this enrollment. Through COSH, we gave a recommendation for a certain percentage of enrollment just as a goal. And most of the HRIs have already exceeded that. So we're really, really proud of the work that's been done in just engaging the obstetricians in these pilot regions. And we will see the fruits of that labor soon, I am sure. Trait is working on the dashboard and the data capture. So we'll be able to come back with more specific metrics in future meetings.
All right, very good. Again, there'll be more information in just a little bit with some of the numbers and what's going on with the rollout. All right. The collaborative care, Monica, I saw you. I think Andy's not here. Do you want to give an update on the collaborative?
Yeah, that's correct. Actually, Hani Talebi on our team is going to give that update for us.
Hi, everybody. Good morning. Hope you're all doing well. Appreciate the opportunity to give an update on our ARPA Pediatric Collaborative Care Initiative. I think we have a few slides to share. Apologies in advance. I'm sure your slide saturated, but we'll keep them brief. Relative to our metrics, looking kind of in an overall sense, we have a couple of different specific benchmarks we're targeting. One is the population of initially reached children, youth, and adolescents that are recruited for this initiative. At this point, as of September 30th, we are almost halfway there with respect to reaching that 50,000 children benchmark. And then the health systems committed. Also, we are very close to that first year benchmark, having 7 of 9 health systems overall committed. We see this increasing beyond that number 9 in the coming months here, both with internally affiliated as well as community-based sites recruited for this study. We should be in good shape across both these benchmarks as time progresses. Next slide, please. So what have we done so far? In a concrete sense, one aspect that has proven particularly helpful for folks is putting together some sample job descriptions, specifically for the behavioral healthcare manager role and the psychiatric consultancy role. We've provided these to all the HRIs to ensure that they can get their own names on them and make them unique to their sites and post those if they are going to be hiring personnel, as opposed to having them pivot the excellent staff they have. We've also highlighted roles and responsibilities for the 3 primary stakeholders involved here: the Meadows Institute, the HRIs, and the participating health systems. So differentiating between who's doing what and across what timeline. That's all been provided to folks. And then we provided a health system kind of readiness assessment to the HRIs participating so that they could kind of have a roadmap of sorts for questions to ask when determining whether or not a particular community-based or even internally affiliated site is a good fit for this initiative. And so that has proven helpful as well from a practical standpoint. Next slide, please. So TA, technical assistance, obviously is a huge part of making sure that we're following the collaborative care model with a high level of fidelity, but also making sure that folks have a good understanding of exactly what steps need to happen in a temporal fashion to make sure that we're reaching these benchmarks and creating sustainable models across time, both from a fiscal standpoint as well as a personnel and a clinical standpoint. So KII's key informant interviews, we've been kind of facilitating those to make sure that we have a very good understanding of the current state of measurement-based care across ADHD assessment on the PED side of things, as well as some of the more high base rate presentations for anxiety, depression, et cetera. We have crafted a TA series It's topically based, and we'll be kind of crafting that in a sense to be supporting implementation across time, but making sure that there's both the ubiquitous as well as the unique aspects of implementation covered across all the different HRIs and the health systems that will be carrying this out as time progresses. We're looking at pediatric best practices. We have conducted already a literature review looking at exactly how best to approach this conundrum, knowing that we have really rolled out collaborative care by and large to adult populations. So historically what happens is you just take the adult model and cascade it down, but we know that that's not really a good overlay for this initiative. Instead, we're talking to folks who have rolled out pediatric collaborative care, sometimes in smaller independent practices, sometimes in group practices, and sometimes very rarely in health systems. So we're bringing all those folks together and talking about that framework from a clinical model best practices standpoint, and we'll be disseminating that as time progresses. And then our health related institution cohort, we're looking at reviewing the roles, responsibilities, templates for reporting, and all the different components as we meet regularly to discuss and explore how things are progressing. Next slide, please. Some of the highlights from the HRI side of things, many have held conversations with health systems interested in implementing collaborative care. It's a lot easier, obviously, when they're internally affiliated and you're just kind of recruiting colleagues and a practice to be a part of this, but always a little bit more challenging to get out into the community and figure out what will and won't work based on current practices out there. So it's encouraging, though, to know that folks are opening these dialogues and it's moving forward. And then some HRIs have already posted those behavioral health care manager positions, job descriptions, and looking for psychiatric consultancy as well. That has been identified across a few different HRIs, both internally and externally. Next slide, please. So what's coming up next down the pipe here? Later in November, we are going to have our monthly HRI-wide meeting. We'll be covering both pragmatics as well as some of that TA stuff that we already mentioned. And then November 15th is our monthly reporting deadline. So folks were really gracious and wonderful in the month of October of turning things, submitting and turning things over to us very quickly. So we see that moving forward well. And then we'll be providing additional resources. That pediatric collaborative care best practices framework is partially completed, and we're in the space of hopefully getting that into a presentable state in the next couple of weeks here. And then forthcoming around the corner will be the additional recruitment of health systems through HRIs and supporting them in that process. Those TA opportunities month to month, monthly metric reporting that we'll be able to really look at the data and determine if we're making headway relative to those benchmarks. And then in early 2023, we are facilitating in a collaborative between Meadows Institute taking place at Dell Medical School, a pediatric collaborative care roundtable. We're inviting some of the thought leaders and some of those frontline providers that have actually implemented pediatric collaborative care across different sites in the country to come together and really focus on some specific targeted questions that we are going to be parlaying into this study, both from a TA standpoint as well as best practices relative to the clinical model. Next slide, please. That may be it. Yeah. Any
Very
questions?
Good.
Yeah.
Thanks, Annie.
Sure.
Any questions for Dr. Talebi? All right. Annie, I don't see any hands here in this room or anybody raising their virtual hand. So again, thank you for moving this project forward. Yeah,
You got it. No worries. Thank you. Appreciate it.
All right. Dr. Blader. Joe, you want to give us an update on the substance use disorder pilot?
Yes, I'll be happy to give a brief summary of where we're at. Two of our 4 sites are accepting referrals, have begun seeing patients. Those 2 are here at San Antonio and UT Houston. Dell and Texas Tech are on the cusp of doing so as soon as they're done finalizing their teams and getting people onboarded. So we hope to have all sites operational within the next 1 to 2 months. And then at that point, I expect to be able to share our metrics with respect to number referred, number seen, number completing care, and dispositions and other hopefully clinical indicators of outcomes. With the expansion of TChat to a number of more sites, including not just traditional schools, but also the expansion into, as we discussed last time, the recovery / alternative high schools. That's potentially an area where we could make a very significant impact. So, but in that context, we would then be offering ourselves, as they say, holding ourselves out as a substance use treatment program, which therefore brings 42 CFR Part 2 concerning the various confidentiality provisions for individuals who are receiving substance use related care in a program that holds itself out as a specific service for that. So we've begun some discussions within our site, how to there might be some special issues concerning how we configure the medical records and access and that sort of thing, which hopefully will be surmountable enough that we'll be in full compliance with those provisions. So those are the main things going on. We've also begun to execute a contract with the Partnership to End Addiction, which provides specialty training, consultation, and ongoing supervision for family-based treatment for adolescent substance misuse. So we hope to have updates on the progress and uptake of those training opportunities for all of our sites.
All right. Very good. Any questions for Joe? All right. Dr. Blader, it looks like there's no questions here in this room or virtually. So again, look forward to seeing this pilot roll out completely in these 4 areas, and the data and all that information that will be upcoming. Sounds
Great.
good.
Thank you.
And on the 42 CFR issue, if we need to talk later to try to figure out what that path is, maybe we set up a meeting later to think through that together. Okay.
Will do. Thanks for the support.
Yep. Thank you. All right, let's go to the youth aware of mental health, Dr. Trivedi.
Thank you. Happy to give a quick update. Let me bring up the slides. So things are moving actually quite rapidly, and we are now trained facilitators at all of the HRIs, participating HRIs, and they're starting. So we've had a series of training sessions, and every time 22 people come. We started in March, then another one in July, 2 in July, then we did 1 in August, 1 in September, 1 in October, and 1 most likely will end up having to do it again in December. These really are very intense 5-day training sessions. And I wish we could tape them. These are really very exciting sessions, and people, once they are here, they really actually become quite adept at doing YAM in their local HRIs. So we've now trained 125 instructors, and the next training, as I mentioned, is scheduled in December. We have all the participating HRIs have at least 2 and a number of like TAMU Lubbock, San Antonio, and Bell have 11 to all the way to 14. We have obviously at UT Southwestern been doing this for some time, so we have a much larger pool of facilitators, and we can actually even send them to schools in local HRIs when they are in a pinch. And I'll give you a little, it's an interesting, really a challenge, and the work process and workflow is an interesting issue. Is like, for example, this week, we are in Arlington where we are doing 31 classrooms. And so that is really huge, and therefore we may need sometimes to have bring in people, facilitators from some other place to be able to move that kind of volume. We'll get to 900 students this week. So these are all the school districts that have been engaged by each of the HRIs. I have to say, as people have been repeatedly saying, this is actually very impressive. Each of the HRIs, which started from scratch, have now a number of ISDs all already in motion. And as you can see from the asterisks in all of the HRIs, a number of them already implementing or currently this week doing implementation of YAM in a number of these ISDs. So this is, as you all know, getting an ISD to agree to do this takes, and we insist that there is a whole memorandum of understanding. Everybody recognizes and understands what they're agreeing to. So it's not just lip service. So it takes time and effort and real engagement. And I think that it's really, UT Tyler, for example, is already doing it in 2 ISD right now. And the other ISDs are in the process of getting launched in terms of implementing, but they have already agreed. So this is really very exciting, and I cannot thank all the HRIs and especially their school TChat folks to have done a fantastic job. So we started this process in the spring, at least in the North Texas area, and we continued in September, October. This currently we have about another 1,500 students getting this program, so that by the end of November, we expect to have already reach 5,000. This obviously, as you know, is beyond the original estimation. We are in classes enough on a very rapid clip, so we will be in about 300 classes by the end of November. Like we said, 5,000 students, 300 classes. This week, we are delivering in about 75 classes across the state. So this is thankfully moving fast. One of the humbling realities of this, and it gives us all both pause and actually confirmation of why we are doing it. You can see the distribution of kids when we just do a PHQ2 and PHQ and a GAD. So these are just 2 screening questions. Remember, we would eventually love to do larger investigation to really get a better full picture. But right now we are doing this as a real mass implementation. So we are restricting to specific questions so that we don't overload the system, we don't overload the facilitators, and clearly don't overload the students. But 25.8% of students will score more than 3 or more on the PHQ2. Tells you that this 25% of students are not totally well. In fact, a number of them will have actually depression. We just have to now move to the next step as we move forward. This is this is really, we shouldn't let people worry that we are going and doing something with kids who don't need it. This is really tells you this is really essential. Same thing with anxiety. About a quarter of them have significant enough anxiety that one should do something about that anxiety. Otherwise, that will have 3 things. A, not good, it's a medical issue. 2, it'll negatively have an impact on their education. If you are a teenager and you have this amount of anxiety on your 2 screening questions for anxiety, you're not learning as much as you should. So I am going to try to stop here, but I thought one of the other things might be helpful is to see, we have been a number of systems, number of places are doing this. So I am asked at least two people, Dr. Pardivala in San Antonio and Jennifer Rojas Vinny at Lubbock, and she and Dr. Wakefield both can comment. So I want to make sure, because people have wondered, and we have always wondered, should it just be, should kids in school just get one thing and that's it? Or should there be more things, or what is happening? And once you do it, how easy, hard it is, etc. I can keep on talking about it. You see the data. But I thought I'll ask them, if you don't mind, to just give their thoughts. So Rena, thank you for joining, and Jennifer, I think, is somewhere. So can you, Rena, start and just give your thoughts on how it has gone?
Yeah, absolutely. Thanks for having me here. My name is Rena Pardawala. I'm the clinical director for TChat at UT Health San Antonio. And I can't tell you, when I first was learning about YAM, I was like, what's YAM about? And I wasn't quite sure. And when I went to the training, I was blown away by this training. I can't even tell you how valuable this training is and what it offers students. I think that there is an environment that is created through YAM for students that really is very different than what students ever see in any other environment. The environment we create is such an environment of collaboration and non-judgment, and such a neutral space for students to communicate, share their ideas, and really grow in their mental health education understanding. It's truly an environment I feel like we don't see in life as humans often. And to be able to offer this kind of opportunity for students, I think it's going to provide such significant improvement in mental health. I can't tell you how valuable I think this training is. We have seen so much receptivity with schools, which is more exciting than ever. So we had that on this, on Dr. Trivedi's slide, we showed a few of our districts, but since the last time we provided this information, we now have 17 school districts that are interested in YAM. So we've doubled in the number of school districts, I think, in about a week and a half, basically. That's when this last information was provided. The districts are so receptive. We have at UT Health San Antonio, we're currently partnered with 52 districts, and we have about 15 districts that are in the process of partnering with us. And I would say almost 100% of the schools showed up for the YAM presentation. Toby Fuller, Dr. Fuller was the one who presented for us. And we had over 120 people that attended all of our events, our three YAM events to share. So the receptivity of the schools are tremendous. When we share about YAM, it's one of the first things. We get so many questions and so much interest. It truly is an opportunity to provide a mental health curriculum, just like we provide a physical health curriculum during the school day. It truly is that opportunity. So we're really excited about the opportunity to offer this to all of our students in the state. We know the impact it's going to have. We haven't had the opportunity to actually do it yet, and Jennifer will get to share with you what has been on the ground running, because they have done it a lot there. But we are looking forward to starting right here in November. We have our first district signed up to start. And next semester, we expect to get slammed, actually, with the number of schools that want to have YAM offered. So we're very, very excited. And we look forward to this being offered everywhere in the state.
Yes, and similar to Rena, we are very excited about YAM. One of the things that I have really found helpful with YAM is that you can implement the curriculum with 8th grade students. So you can go as low as 8th grade. It had been piloted with 7th graders, but 7th graders just aren't at the point that they need to be to have the dialogue and discussions. But what we have found in part, and what we're hearing from some of the local mental health authorities across our region, is that there is a request from districts for programming or curriculum that they can implement with younger students. And so this is just that. It is an answer for a request that is coming from the districts. It is also a collaboration that we can work with our local mental health authorities as well to continue offering services to them. And there is a high interest in this program. What we are seeing is, our region is a little different than San Antonio or Houston or Dallas or whatnot. And we tend to be very spread out with many rural districts. And that's where we see a lot of interest, is in the rural districts who feel isolated and that there is not much support and they don't know how to have that conversation with the students or what to say. And this is a way that you can bring people into the classroom to do just that. And they have been very excited. We started back in January with one of our first districts and have continued. And we now have districts signing up this academic year to continue offering those services. We've had basically a split between the numbers of 8th graders and 9th graders. Some of our districts want to work solely with the 8th grade population, and some of them prefer for us to work with the 9th grade students. One of the things that we use in communicating out to the districts that we're working with is to say our plan is to help the district create a culture of mental health literacy, of the knowledge, of the resources, of knowing where to go when they need help. And that's what we are able to do with the program. And so when you start with 8th graders and you're training an entire grade level, every year you come back and you do that, or you do that with 9th graders. In a matter of years, you potentially have trained an entire school campus. And that is what our hope is to do. And that is what all of our efforts have been, is to get to that point in working with the districts.
All right.
You.
Thank you very much.
Thank you
Dr.
both
Betty.
for doing, thank you for taking the time out. And unfortunately, I didn't know how to figure it out, so I sent you my link. So now they see there are 3 Trivedi, so I apologize. But nevertheless, sorry. But thank you guys. I think that what you're hearing from both Rena and Jennifer is something you have replicated in many places. I don't know, Brittany, you have any comments, but I can tell you Tyler is so much farther ahead, and we keep on, So thank you, Brittany and Tyler also, and all of you. So before I end, maybe Sarah, any additional thoughts? We talked yesterday. So.
Well, I guess there's just always the concern, Andy Keller says this a lot, that we can't educate people about this enough. And so there are these, I think there are other programs that have been rolled out, and in some of those areas, those are working very well, and local mental health authorities are partnering with schools to provide team mental health first aid. And that with all of our consortium projects and programs, the goal is to fill in the gaps and to bring, some ability to evaluate what we're doing and how it's impacting the students and the kiddos with whom we're working. And I think that this program does that. And as you heard Dr. Rose McQuinney say, it's a different age population. It goes to a younger age group than the team mental health first aid, but this in no way means that those kiddos couldn't get that later, that we really have a long way to go in improving our mental health literacy. And this is another step towards that. And we're really excited to be able to partner with schools to do that.
And I have to say, I justified with the legislature, and we don't give enough credit to the non-medical people, but at least at the legislature level, they understand there cannot be one solution to every mental health problem. Because if that is what we want to be depending on, we are losing battle. So there may be, we need many things. So that's the issue.
Okay. Very good. Any questions for Dr. Trivedi? All right, Manuka, I don't see any hands here or any virtual hands. So again, thank you for the update and the work to roll this out.
Thanks so much, Dr. Padiwala and Rojas.
Yep.
Thank
All
you.
right. So Laurel, you are next, and there are several things here. Is starting off with the safe alternatives for teens and youth. Last time you integrated that into the COSH update. So why don't we go ahead and I'll let you kind of prioritize the different issues here. but we're going to lose a couple of executive committee members in about 30 minutes. And one area that we have a couple of votes is on the CPAN component. So if we could go through maybe that part first and then touch on some of the other areas, I think that might be helpful if possible. Does that make sense, Laura?
Sure. You want us to do our cost slides now because it has that information in it? Okay.
Yep, why don't we go there?
Okie dokie. Edith. Oh, look at that. Right on top of it. So, hello, welcome to October. Go ahead and go to the next slide, since it sounds like we need to be super efficient with our time. And moving to the next slide and the next slide. So, we want to thank the executive committee for your input about sort of the conversations we've had on the phone process and how to make it work better for the providers who call in, as well as be able to more clearly have metrics that are practical, stick to our charge of getting to the phone calls quickly in a busy provider's day, and having a metric that will be standardized across all the HRIs that can roll up to the statewide, so we can have a good sense that we are doing what we've said we're going to do. So what we've talked about with the vendor, as well as with the CPAN leadership team, is the following process that we'd like the executive committee to consider, and if hopefully ask any questions and then potentially vote on this process if we agree to it. So currently, when the phone rings and they are asked to pick an HRI, they then will hear the phone ring as a provider and until it gets picked up. And then if it rings a certain number of times, and then they would get a voicemail. We'd like to move away from a voicemail option, instead move directly to just answering the phone and not have voicemail during the day. The voicemails will come on at the end of the day, so that when somebody does call after hours or before 8 a.m., they could still leave a message and ask for it to CPAN to help them. So, but it won't be during the work hours where we're expecting for our team member to get to that phone call quickly. So the new process would be that the provider would go to the HRI that they need to be at. Instead of hearing ringtones, they would hear a recorded message that tells them that they've reached the CPAN line, that they are in queue to have their phone call answered. Remind them also that we have an option for them to use a texting if they prefer to text us. And that process will have them on hold while our internal team is all being rung to pick the phone up. We'll be standardizing that process so that the caller would theoretically wait for 5 minutes. We're hoping that they will not. But by that, the team will pick the phone up and go on the call. And so what we'll be able to see is the average amount of time that somebody is waiting in that queue for the phone to be picked up. If if an HRI is unable to pick the phone up, then it will transfer automatically to the next hub. The provider won't feel that change. It'll just be the continued listening to the message until the team member picks up. So what we will do is have the metric that we'd like to replace the callback within 5 minutes after a voicemail has been left is actually average amount of time that somebody's waiting on the phone before the team member picks the call up.
All right, very good. So we have this proposal to change the process, the protocol for kind of delays in answering the phone, and you see it in front of you. Is there any discussion or any concern? Hearing none, is there a motion to accept this?
I move approval.
A move of approval. And a second from Dr. Podolwitz. Any other discussion? Hearing none. Hearing none, all in favor, signify by saying aye.
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 Thank you. I actually do want to give a special shout out to Dr. Eberson. He was the one who made us go, well, why are you even having a voice message? Just pick the phone up. So it did cause us to go and search for that. So we will talk with our vendor about making these changes, and then we will work to implement it. And when we have, we'll start sharing that data when we have it fully implemented.
And Laura, but before we do that, just want to be careful here. Was there anybody that was voting against this?
Oh, sorry.
Or anybody abstained? Okay, hearing none, then it's unanimously approved. Okay. Thank you very much, Dr. Williams.
Thank you. Sorry, my glasses are really bothering me today. Next slide. Okay.
Yep.
So the ARPA initiatives for CPAN specifically that are separate from the Meadows grade update. We have worked through a pilot process for texting and used our team members' feedback as well as provider feedback, and then work with the communication team to talk about how we could communicate out to providers about this process. They've been really, the communication team, Laura and Melanie, have been super fantastic. So we have a goal to launch the outreach to providers to alert them that they have an option to start their consultation process through a texting process instead of being on the phone. So that it's slated to start actually next week on Halloween, Monday. So we're excited to see if that will help busy providers in their day initiate the start of a consultation. To be clear, the consultation does not occur in a texting process, but it's a way to kind of get their place in queue to have our team member help them directly and/or help their team, like their nursing or other members of their team with a particular question that they need CPAN's help for. So we're excited to see that process roll out this Monday. The next process is direct consults. We have currently 5 teams piloting. This is, again, for those who may not remember, this is when our child psychiatrist on the phone with a provider listens to the question at hand and feels that what might be better is an educational consultation directly with the family and child in an appointment outside of the CPAN 15-minute sort of consultation. That process requires obviously consent. The family understands that this is a one-time visit. It's not to start care, but to provide consultation and educational teaching points to the PCP that's seeing the patient. The closing of the loop is a letter that's sent out to the provider, as well as an actual another phone consultation to go over the findings with the PCP. And if there's findings include that the PCP may be able to do some of the direct care themselves, then kind of coaching about how to do that. If it's additional to get them additional services or referrals or resources, then the team would do as we would normally do and help that, including if they do need a psychiatrist to help them find a psychiatrist as we currently do. That process, we hope to have the sort of final amount of sort of piloting of this in these 5 teams by the end of November. We have started to talk with all the CPAN teams about sort of how to some of the sort of technical aspects that they need to start working on at their individual HRIs in order to be able to kind of consider a launch early in the beginning of the new year. We're thinking sometime January, February, to start allowing this process to become a statewide opportunity for education to the PCP on how to sort of help children and their mental health disorders. Yeah, go ahead.
So Laura, kind of what I'm hearing is, so we've had this pilot with the ARPA dollars. There's some other institutions that have said that they can do this within their current budget, and a goal that at some point that we be consistent across HRIs to say, this is what the CPAN model in Texas looks like. If there's a child that really needs a in-person visit to provide an appropriate consult, then there is that opportunity within the Texas CPAN program to do that. And so I think this is one of the areas where we need feedback from our HRIs. Is this going to be a major challenge for any of our HRIs? I think from the pilot, Laurel, we should get a feel of how often this will be occurring. Right now, it's a little bit, unless you have some data, a little bit of a we don't have the data to say what proportion of the consults would need to come in to be for that in-person visit. But at some point, we'll have that data and use that then to help our institutions decide, is this feasible or not? Laura, is that correct?
I think yes. The way that I would add a few points and then I'll pause for people's questions. We have talked extensively with the Lifeline for Moms. We have a consultation for PeriPan. And so not to talk about PeriPan specifically, but we've gotten a lot of information about that process, and also talking with Dr. Servette with McPap, which we are the most directly modeled after. And in speaking with both Dr. Servette and Nancy Byatt, their sort of sense for MCPAP, for the children's piece of it, is that we actually are appropriately staffed now to provide direct consultations, and that their Dr. Servet's opinions that we do not need additional psychiatrists to provide this service from his perspective. His team currently in MCPAP has about 60% of the work that their psychiatrists do across the state is providing direct consultations. So our goal is to, as you said, hopefully standardize it and say it's an option for all teams. If there is individual HRIs that may not feel that they have the ability to have their own team member do a direct consultation, then we are going to talk about how other HRIs could potentially, because these are virtual, by and large, are going to be virtual visits, that another HRI could do the direct consultation in their stead. But yes, we certainly would want to show some data. I think the challenge a little bit, Dr. Lakey, about the data is that we had a smaller number of PCPs who have agreed to participate. So I don't know that they will actually be a good measure for how busy we could be. And that's why I looked more to Dr. Servet. When I also talk at the national level to other teams across the country about their programs, this is becoming pretty standard for most of the CPAN type consultation programs in the States. And the ones that continue to not offer it have continued to have lower collaboration and lower consultations with primary care. So I think we need to look more to the national data and sort of our experts, particularly with Dr. Servet, than to say that our pilot data will tell us, what we should do from a staffing perspective.
Okay. Dr. Wakefield, I saw your hand and then just disappeared.
Yeah, I only had a couple of other points. Dr. Williams really pointed out most of them, but that just doubling down on that this program, the Access Project or Access Program, is to build capacity in our frontline clinicians. And that from the Lifeline for Moms team, who really does look at all of the different programs for the perinatal project across the nation, is their expert opinion that this is the piece that actually improves engagement and builds capacity more than any other piece of the programming. So that the clinician to clinician consultation builds more than the delivery of resources and referrals, but that the direct assessment or face-to-face consult builds that capacity. And just wanted to clarify that this face-to-face consult is really a one-time evaluation for someone that you do think can stay in the pediatrician's office if you have clarification of diagnosis, but that it seems too complicated to understand that diagnosis in the clinician to clinician consultation model. So this is to clarify the diagnosis so that you can help with this treatment plan, but that the patient remains in the care of the PCP or obstetrician. So just wanted to talk about that there is data now that we have from Massachusetts that shows that this piece is the piece that builds capacity more than the other pieces.
And Sarah, it sounded like from your conversation and Laurel that many of these will be through telemedicine versus actually in the clinic. Is that correct?
Yes.
Mm-hmm. Okay. All right. Any other comments from any of the executive committee members? Another?
Hey, Dr. Lakey, this is Danielle Wesley. So a quick question for, I guess, the group is that when we started hearing this from our CPAN teams, it started to sound like this is starting to be more of a mandate for all HRIs as opposed to if you can manage the capacity for the direct consults. And so I know that we had not talked about this at the executive level. And so just wanted to understand, is this still an option for HRIs if they feel that they've staffed to the level to be able to augment for direct consults? Or I guess what's the feeling now in terms of the opportunity to opt in and or opt out?
Yeah. So I think that's why it needs to be discussed here in the executive committee versus the CPAN group. We need to get that feedback from all the participants on, is this doable or not based on your staffing levels, et cetera. You've heard of the importance of it. But I also know we have 12 institutions and things are different in different institutions. And so I think we need to be careful of assuming anything about what one institution can do versus having them express to us what they can do. So there isn't a mandate now. We are looking at this as an opportunity and having the discussion to see whether this is feasible or not. Danella, does that make sense?
It does. I just wanted to, I know we talked about it a lot, and I don't know if Dr. Taminga had any additional input that she wanted to provide, but I know when Lynette and the team came out, we did discuss this. Our providers were very vocal about perhaps not staffing to the level that they believe that these direct consults will create the capacity internally that we'll be able to handle it.
Okay. Alex, Dr. Vo?
Yeah, I have two questions. The first, they're kind of related, but let's just say it is rolled out statewide and our HRI providers are able to do the direct consults with the patients in the primary care clinic via telemedicine. Since this is an ARPA initiative, the support for that, I assume, will end sometime down the road after 2025. So my two questions are, one is, once we're able to actually see these patients, can our HRIs drop claims for those patients? And then secondly, will the PCP sites be able to drop a facility fee claim to help incentivize the ongoing sustainability of this project? So I think these are two questions that will probably need some legal review from your side, if you can look into that.
Yeah, so Alex, I guess what I would add is right now in our request to the legislature, we're asking for the dollars to continue these projects and to expand these projects. And so we can look at whether the feasibility of dropping those claims, but we're also trying to make sure that there isn't a gap as we go from ARPA to GR funds for sustainable funding for these initiatives. Does that make sense, Alex? Okay.
I would clarify, Dr. Vo, we're not planning to do these visits at the pediatrician's office. That certainly could be in some places where maybe the families don't have access to Wi-Fi in their home, but we've all become very familiar with doing patient care with parents present at their just homes. So the anticipation is actually more that we would primarily be doing it to the family in their home. Sometimes the family may need to travel because of the child's age and not suitability for remote and or we may want to occasionally partner, but that's a very limited amount of actually doing it at the pediatrician's office, for example.
Any other comments? So Laurel and Dr. Ibrahim, let me go to you next.
Yeah, I mean, I just think, this could be a natural next step, but I do think that decisions that could impact how you staff these initiatives really don't belong to the work group, they belong to this committee. This is where they need to be discussed. It's just a comment in general, not just specifically on this one, but in general, this is the committee that actually is overseeing the work.
Yeah, no, I agree. And that's why we're having this discussion today. And what I think is probably the next step is that you've heard this discussion today. I don't think we vote on a decision today, but let's gather information from our HRIs on whether or not this is feasible and a timeline on whether that would be feasible or not. And then let's come back to the executive committee to lay out that information and have a further discussion. It seems like this may be the next step, but I want to be very careful that I don't saddle any of the HRIs with an obligation that they can't do now. And so I want to make sure we get that information and then come back to the full executive committee and lay out what that plan would be. Steve, Dr. Plitzka?
Yeah, one broad question that's related to this, like what the subtext that I'm sensing is, people say, we don't have enough of the psychiatrists to do all these projects that we have funding for. In other words, like you said, David, we put the money in to continue the ARPA projects. There's money available, but, people may be saying, I just don't have the staff.
Yeah.
And I don't have the psychiatrist in particular. And it's interesting, I've had conversations with a couple of people at HRIs run into the same problem I have. The money may be sitting in the account, but if you post a position, say to hire a new psychiatrist at, I'll just throw some numbers out here, 260,000, and all your assistant professors are at 230, you run into equity issues. And of course, you can't raise everybody else's salary so you can pay the competitive salary to really recruit the kind of people you want. So we end up in this situation where, we don't have the people we need. So, I think this, I'm asking, I guess the question I'll ask right now, is this the problem do people agree that this is a problem? The salary equity vis-a-vis what the consortium can pay versus what private practice can pay, and whether that's a discussion we need to bring up in terms of how you equalize salaries across psychiatry departments in general. So the psychiatry departments aren't constantly sort of behind the curve in terms of competing with private practice, or even sometimes with community mental health centers or the VA or other kinds of institutions, because our graduates have a lot of choices. And I'm not suggesting we take that up today, but I see that as a subtext that's going to keep coming up.
So
go ahead.
Steve, from our perspective, I mean, for those department or HRIs who are not situated in the larger cities, but actually in the smaller cities, the problem is not so much equity, it's simply bringing people in. Getting more psychiatrists in the more rural areas of Texas is extremely difficult. Competent psychiatrists, child psychiatrists specifically. So I think this is the main reason, at least from our perspective, why we cannot expand, is because we cannot, we already expanded as much as we could. We're still in the process of hiring continuously, and we just cannot get appropriate candidates. So it's not only the question of equity. I would pay the difference and I would pay the money if I just get enough good people. So I think that's they're probably not. I mean, I'm not saying that what you just mentioned is not an issue. I'm just saying that we have additional difficulties in the areas. Yeah.
So yeah, thank you, Israel, and thank you, Steve. I think every time we've had a hearing downtown, we've brought up the workforce issue. It's a big deal, and again, as I've told the legislature, they can give us as much money as they can. If we can't hire the people to do the work, then that money just sits there.
Let me throw out a quick idea. That for the legislature peg all UT salaries, at least in the mental health area, to what the VA is paying. If we could do that, I think I could fill every position and more. And they might have to, in other words, give enough of a state appropriation across the board, separate from the consortium. We wouldn't have some of these equity problems that prevent us from offering a higher salary to someone who's doing the consortium work because someone else at the same rank doing similar types of mental health, a similar seniority, is making less. But you can't raise the person's salary is making less because the fee for service, the contracts you have, aren't paying that. That's kind of the general sort of brainstorming that I'm thinking about.
Yeah. No, thanks for that. I got to be careful. I can't promise that. I think that would take a lot of conversation with the legislature.
Right, absolutely.
But let's have that conversation and continue that conversation. And I think that's also why we have our fellowship slots and why we're doing CPWE, is to build that workforce here in Texas so that we aren't as limited as we are right now. So let me go. I see 4 hands. Ndukur, I'm going to go to you, and then Brittany, and then Dr. Ibrahim and Dr. Chaminka.
My point is actually just wondering about this, because I've spent a career trying to develop primary care networks because we don't have enough appointments available for psychiatrists. This is a little almost kind of contrary to that. So maybe CPAN staffing is a different thing, but I think that is something we have to be mindful of, is that unlike rest of medicine, I think we are in the business of saying everything should go to psychiatry, and that has not worked. So how this will work may be interesting to see.
Okay, very good. Brittany, you're next.
Yes, I was trying to say, we have an internally for us, a lot of it is the pool that we have waiting lists for child psychiatry in our outpatient clinics. So we hired, consortium docs in the beginning, and then as these waiting lists pile up, we have people on the operations side kind of looking at, for example, the number of consults on CPN versus, all of these kiddos waiting to get in for treatment. So sometimes that becomes an issue.
Yep. No, I've heard that in a couple levels from your institution. Thanks. But Ibrahim?
I was just gonna say, the issue is not just finding the psychiatrist and paying the psychiatrist. The changes like this, like using telehealth, there are other costs that needs to be taken into account. So when changes like this happen, we just need to have a discussion so we have actual appropriate budgets. I mean, telehealth does not come cheap if it's only telehealth. And of course, if we have in-clinic visits, that's also another story.
Yep. All right, and then Carol.
I just wanted to say that at UT Southwestern, our salaries are set within the school in comparison to our community and our school and the other salaries at the school. I can't set salaries at UT Southwestern for what some other school in another city sets salaries. So I think that's a non-starter from the start.
Okay. So again, I appreciate.
But that was kind of my point. If the salaries are set, you're constantly stuck. Your graduates come to you and say, well, I can get more elsewhere. And then we can't raise it to meet what the market. There are obviously going to be variations between institutions based on cost of living and things like that. But I think if we don't look at this issue of, the academic salaries being chronically below what private practice is paying, we're always going to be in this issue. We're always going to be in this trap.
Well, Steve, that's the job of a chair is to get out of that trap. And every chair has their own way within their own school, and I can say what the going salaries are in the community, and my superiors have to take that into account. But still, the state can't legislate that. I hope they don't.
Well, not legislate it, but to be aware of the problem, so that we're in a poorer community, so we have many more people with Medicaid unfunded, so it's a lot harder for us to generate fee for service. These are the kinds of things that create issues.
So let's go to Dr. Nimroff, and then I'm going to close this part of this conversation. But Charlie, you want to go next?
I think this conversation is a fool's errand. I don't think that we're going to solve this problem. I don't think David can go to the legislature and find a way for us to deal with the chronic problem that we have, which is trying to compete with the private sector in order to hire psychiatrists and psychologists. Mm-hmm. And I just don't think there's a venue for us to be able to do that, or a pathway. So I feel your pain, Steve. I feel it every day, but I don't think we can fix it.
So as I noted earlier, again, thanks, Charlie. I think that's why the fellowships that we've been developing, again, we've more than doubled the number of child adolescent fellowship slots here in the state of Texas. I think that's why CPWE is so important, because we have to build that here internally in the state of Texas. I think on this issue that Laurel brought related to making that in person or through the televisit for consultations for CPAN. I think we need some more information, because there's some of our institutions that are ready to do that. There's some that have people that have been hired with our consortium dollars where their time hasn't been fully utilized, and this could be a good use of that time. But there's others that aren't quite in that same situation. And so we will send out some questions to each of the HRIs and see if we can gather that information and figure out what is feasible and what is not feasible, and figure out if there's a timeline to move this forward. Okay. With that, Laurel, let me turn it back over to you for the rest of your update. Thanks.
Sure. I just want to say one more thing, though, that we're not talking about just a psychiatrist, to a few people's points. That's why we went to the teams and said, hey, here's what's going on with the pilot. Please talk with your HRIs about what your concerns are. So this is exactly what we need to be doing. So we actually have 12 psychiatrists on every day of the week from 8 to 5 and for CPAN. So we are actually just talking about how we can better utilize those individuals, as well as how we can coordinate with each other across the hubs and not have to see that every single hub, has to double their staff in order to do something. So we are talking about efficiencies with the staffing that we already have, but it is more to several of your points. It's more than just a psychiatrist time. It's having staff member time to schedule the appointments, having funds for other things. So that's why we did ask for each HRI to go and start these conversations. So I do appreciate that. So I just wanted to remind us all about the number of psychiatrists that are currently in CPAN. And that's what Dr. Servet is suggesting, that we actually have enough psychiatrists to handle the consultations on the phone as well as direct consultations. But I think the other elements of making the visits occur or where we want to really also think about is for each of the teams too. For PeriPan, as Dr. Wakefield said, we had set a goal for each of the teams to enroll at minimum 25% of the OB-GYNs in their regions by the end of October. And I think some of them are either already past that or very close to making that goal. We have the key metric report that's available that actually came to each of the teams a little bit earlier than we anticipated with the trait team. As far as the dashboard, the visual, that is going to take a little bit longer, in part because we're actually thinking about the dashboard that we currently have and whether or not it's really showing us what we want to see. Now that we're kind of in another phase of our programming. So I think before we ask to build a new dashboard, we actually want to just start looking at the data and deciding what do we think is important of that data. Back to also to Laura's presentation, looking at some of the other data that might help us be more effective in our outreach and communication to our regions, both for PeriPan and CPAN. But there's a couple of different ways and different data sets we could look at. Next slide. So she's going to just share briefly the dashboard. So she's just moving together. So this is the CPAN for the previous month, September. And I'm just filling space until she's got it up. It's like the Jeopardy song. Do, 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 do. Oh, see, look at that. So as you can see here at our top line of our dashboard, we have 9,428 providers across the state. And private providers, as you may or may not recall, include both physicians, NPs, PAs, as well as nursing and residents. That is within 1,700 clinics across the state. And as of end of September, we had completed over 13,000 consultations with an estimated 12,000 patients being served. Remember, those numbers don't line up because sometimes the provider calls about a general question and not about a specific patient. We have set the metric that we would respond to a provider within 30 minutes. And you can see here across the state, our median response time is 6.4, and we were able to hit that metric a significant amount of the time at 99%, essentially. We have a limited amount of providers that are in that pending agreement stage when it comes to enrollment. So our teams have been closing that gap for those clinics that were still on the fence. And as you can see here, the clinic types, we have pediatric, family medicine, integrated. The other clinic types are going to start to include the PeriPan clinics. And as we start to see more enrollment there, we'll be able to present that data to you. Moving down to the next part of the dashboard, we'll stick here for the remainder. You can see that we've had, if you can hover over September, we've had our highest number of consultations in a month this past September at 859 consultations. Most of the teams are seeing growth month to month as far as the volume of calls that they're receiving. And when you go to the clinic staff engagement September metric, you can see that we have providers that have called more than one time. And we're appreciative of that fact that majority of callers are calling us more than once. So this is great to see. And when you look at who is calling us, the vast majority of people are calling us still include the physician and or medical director. And then beyond that, nurse practitioners are sort of the next largest group of providers that are calling us. So we're very excited about that. we're starting to use some of the data very targeted towards the teams themselves to look at their engagement to help them focus on outreach strategies for providers who've yet to call, providers who've called one time, and also how to best engage with our what we call super users, providers who call multiple times. So we've been working with each individual team as well as with the communication team about how to direct messaging in a way that providers will step up and take notice. So we're excited for that. We can go back to the presentation. I just want to say shout out to all the teams. I think all the teams have been doing an excellent job in the last several months to rise to the occasion. Moving now to TChat, we'll be very brief. We just had 2 slides to share today related to TChat. This first slide to give you an orientation to it, these are the number of open referrals. So this is specifically looking only at the month of August and only at the month of September. Any referrals that came before August, for example, are not included in this particular slide that you're seeing, but we just wanted to give you a little bit of a sense of how many referrals have not moved to the next stage in any given month. And so again, the summer months when schools are largely closed, although TChat is still providing services and still getting referrals, we definitely are usually getting much less. And then these, again, open referral definition is a school has sent a referral into our team, but our team has not yet been able to reach the family to get parental legal consent. And so that process it stays as an open referral until we're either able to reach the family, they enroll in the care, or potentially decline the service, or we're not able to reach them. Next slide. And this slide actually shows you the number of unique people that are enrolled in the service. This is a slide that I think is also very important because it shows you how many new unique patients in a particular month. Again, this is not a rolling number. This is straight up only from the month of August, only from the month of September. You can see as school started, we had a significant number of young people not only referred, but where our teams are able to contact the family legal guardian, get consent for care, and hopefully schedule that first appointment. So at the next meeting, I hope to layer on top of this a line that will show you how we did last year. So you can see not just month to month, but also what was the trend line from last year. So that will be something that we'll hopefully share with you next time. And I think that is it for Kosh. Now, except that, I'm sorry, Dr. Pliska needs to speak on data management.
All right, any questions for Laurel before we go to Steve? All right, I see none. Thanks again, Laurel, for all the great work with the Kosh and putting that together. So Steve, we have 2 things listed for you. One is the data management, and then the other is the CPW update. Was there anything that you wanted to update us on CPW before we go to
there's not really anything new that we're continuing to on CPW. We're continuing to work with the internal team, David Lynch, to make sure that the data on the metrics is accurate. And in particular, we'll start surveying the residents on their experience here in the very near future. So that's really the only update I have in terms of CPW.
Okay.
All right. On the DM, a lot of questions have come up about looking at how effective TChat would be. So TChat has built within it numerous rating scales. These are the ones that are most commonly used. So what we did is we requested Trait to look at how often these scales are being done at baseline as well as at follow-up. And they looked at the archived data between March 21 and September 22. And can I have the next slide? Or I'll do it, I guess. So the slides are being used, the scales are being used quite frequently at baseline, particularly the PHQ and the 2 versions of the SCARED scale, which assess anxiety. The CRAFT, the substance abuse scale, and the Vanderbilt are being used less often and very rarely at follow-up. So there appeared to be enough multiple scales being done with the PHQ-9 and the SCARED to kind of look at change over time. So I can have the next slide. So the DMGC voted to have the state statistician prepare a data analysis plan looking at change in the PHQA and the two scared versions. Generally, these are people that are the number of follow-ups after the baseline range from 1 to 5 with variable length of time between the follow-up. So we'll probably look at a statistical model that will kind of be able to handle this, particularly since there'll be missing data for some individuals. We can select some baseline variables as moderators and identify any potential mediators. I believe Abigail Koch is going to present the data analysis plan for discussion at the meeting today. And as we refine that, we'll go forward. And the goal is to have results certainly available for the end of the school year that could be used as really for advocacy, both to publicly disseminate and also if the legislature asks, that data will be available to David and Koch in order to provide that information in terms of meaningful change on symptoms of depression and anxiety. This look is also how people are using the measures in trait, is giving us insight into kind of what more needs to be done in terms of advising teams about how frequently to do these measures and whether there are other variables besides depression and anxiety that we're going to look at. And that's all I have.
All right, very good. Any questions for Steve? All right, I hear none. Steve, I look forward to seeing that data. That will be.
I think our look at just the raw data looks very promising, that there are some very robust effects. So I anticipate it certainly will be not only statistically significant, but clinically meaningful. So we'll hopefully get that to you, hopefully to present at the latest at the December meeting.
Okay, very good. So let me just do a quick check with my team. I think we've gone through every item on the agenda. Is there anything else that we need to bring up that's on the agenda? Okay. So we have down here next meeting, November 14th. I may cancel that meeting depending on how busy of an agenda that we need to put together. If there's things that we need to vote on, let's have the meeting. If there aren't things that it's just informational, then I may cancel that meeting and have a meeting in December, unless there's an objection from the folks around here. But if it's just informational, I think we can wait till December. In the meantime, our team will continue working with you related to following up with the issues that were brought up today related to CPAN. We're going to continue to work on the budget with the legislature and make sure the needs are being addressed. If there's other areas that we can be helpful to you, please don't hesitate to reach out. I think on the site visits, are there any more site visits coming up? It sounds like several other site visits. So again, thank you for hosting those site visits. They've been very helpful to us as we get your boots on the ground advice on how do we improve these programs. So with that, is there anything else that anybody needs to bring up?
Just a kudos to the site visit team. We enjoyed very much the visit. We thought it was very helpful, useful, cordial. So Lachelle, thumbs up, and whoever was there, and your people, we enjoyed that a lot.
Very good. Yeah, we want
here in Dallas.
Very good. Thanks for the feedback. We want these to be helpful.
In Fort Worth.
Thanks, Alan.
Yeah.
All right. All right. With that, I think we're done. So again, appreciate your time, and we'll talk to you probably in December, unless something comes up where we have to vote on an issue to move the programs forward. Okay. Have a great day.
Bye.
Bye.
Thank y'all.
Bye-bye.
Thank you.